بسم الله الرحمن الرحيم. أولا it's my pleasure to begin symposium of Janssen Pharmaceutical Company. والحقيقه ان انا احب الاول قبل ما ابدا الجلسه دهيت بتحيه ماي كو تشيرمان بروفيسور دكتور بهاء عباس الاستاذ بالاكاديميه العسكريه، وارحب بيكم طبعا جميعا. انا عاوز بس اقول كلمه قبل ما ابدا. لو انا النهارده بفتتح السيمبوزيوم بتاع شركه جانسن، فانا بحيي شركه جانسن نظرا لانها ليدر في مجال الاي بي دي. وانا جاي وعمال افكر، شركه جانسن اكتر شركه اشتغلت في الاي بي دي بدءا من التسعينات لما جابوا لنا الانفليكسماب ريميكيد، وده كان في بدايه التسعينات. وبعدها يمكن في 2012 13 طبعا الانفليكسماب ريميكيد كان شغال كويس قوي بالنسبه للكرونز والالسرتيف كولايتس. بعد كده 2012 13 بدأ السيمبوني او الجلوميماب، وده كان سبيسيفيكالي فور ulcerative colitis. وبعدين ابتدوا الدرة بتاعتهم الحديثة الحالية بما انهم currently interested في هذا المجال، وبدأوا في الشغل على الاستيكينوماب او الاستلارة، واللي اصبح اف دي ابروفد من سنه 2017 2018 والسرتيف كولايتس 2019. يعني هو يعتبر حاجه حديثه. ففي الحقيقه ان انا يشرفني تقديم صديقي العزيز one of the figures في هذا المجال، الدكتور عفيفي فهمي عفيفي، الاستاذ بجامعه الزقازيق، وهو غني عن التعريف في هذا المجال، وهيكلمنا على الاستلارا او الاستيكينوماب in ulcerative colitis cases. بروفيسور دكتور عفيفي.
شكرا استاذي الاستاذ الدكتور عمرو فطين، بشكر حضرتك جدا على التقديم الجميل وعلى المقدمه الرائعه الخاصه باليوز اوف biologics especially produced by Janssen في الالسرتيف كولايتس. وبشكر استاذي الدكتور بهاء عباس، بشكر الاستاذ الدكتور سراج زكريا على دعوته الكريمه ليا وعلى شركه جانسن. الحقيقه قبل ما نتكلم I think the question of why biologics in ulcerative colitis، الحقيقه السؤال بقى ما عادش بيتسال، لان البيولوجيكس in ulcerative colitis and inflammatory bowel disease بقى لها success عالي جدا، high rates of remission, decreased rates of hospitalization, less complications في ulcerative colitis, less colectomy. فwhy biologics ده خلاص السؤال ده خلص ما عادش. السؤال رقم 2 when to use biologics. السؤال رقم 3 which biologic to be used. الحقيقة النهاردة we are talking about one of the newcomer of biologics which is Stikinomab, and I will try to position this important drug in the treatment of ulcerative colitis and to try to answer its role in management, in remission, and in maintenance of remission, and why to use it early and why to use it for maintenance. As we see, the journey of success is very important as regards the Crohn's disease, more than 3 years, and now in ulcerative colitis, it's used for moderately to severely active ulcerative colitis who have had an inadequate response with or lost response to or were intolerant to either conventional therapy or a biologic or have medical contraindications to such therapies. Very important whenever we are talking about biologics, we are talking about effective drugs, but also we are searching for safe drugs. والحقيقه البارير اللي بيخلي ناس كتيره قوي ستيل عندها بارير من الكتابه السيفتي اوف these biologics. فيبتدي يستخدم الكونفنشنال ثيرابي ويقول اللي عرفناه احسن من اللي ما عرفنوش. الحقيقه it's not good because now we almost more than 10 years use of stikinumab in different indications. It's used in plaque psoriasis, psoriatic arthritis, pediatric plaque psoriasis, and more than 3 years in Crohn's disease. الحقيقه ال10 سنين دول ادونا very good idea and اللي عرفونا على السيفتي بروفايل of this drug. So when you will use it in ulcerative colitis, it's not a new drug بتخاف على السيفتي بتاعته، لكن it is a drug which almost more than 10 years. نقطة مهمة قوي قبل ما نتكلم in details and in depth regarding immunogenicity. Any one of the biologic agents بيبقى له نوع من الاميونوجينيستي وبيتريجر immune response، والtriggering of this immune response بيؤدي في النهاية إلى loss of response. الحقيقة to start with الستيكينوماب الimmunogenicity after 3 years of study in the PANS study it's less than 5%. لما نيجي نشوف الاداليموماب 23%، انفليكسيماب 42%. انعكاس الاميونوجينيستي this is reflected by loss of response، وبالتالي lasting remission is not present. النقطة دي is very important when you are talking about a drug أو a new weapon you use. قضية مش قضية السعر وبس، لا السعر طبعا له قيمة والإفكاسي لها قيمة، لكن ناخد بقى من الاميونوجينيستي. Again, safety is very important. مش هنتكلم كتير على الافكاسي الا اذا كنا متاكدين، والحقيقه في اي دراج واي دراج ترايل السيفتي از فيرست. لما نيجي نشوف الادفيرس ايفنتس اوف سبيشال انترست we found stikinumab Stelara is 0.48 in comparison even to the non-biologics. It's less than the non-biologics, I mean steroid immunomodulators. So the psoriasis longitudinal assessment and the registry, here they use stikinumab. Throughout the 10 years, we find that the adverse events are very minimal. Now, what about rapid response and the durable remission? هو ده المطلوب. Whenever you are talking about a biologic therapy for management of ulcerative colitis, you are talking about the rapid response and the durable remission. The study which I will present today is a unified trial. As we see on your left-hand side, patients at week 0, they are randomized either to placebo or use of stikinumab fixed dose 30 milligram IV or stikinumab 6 milligram per kg IV. After 8 weeks, that is the primary endpoint or first primary endpoint, you assess your patient whether they are responders or non-responders, and if they are non-responders, placebo non-responders receive stikinumab 6 milligram per kg IV, or stikinumab non-responder receive again. هنا they elongate تمتد الستادي إلى 16 week. After week 8, we are stratifying our patients either to placebo or they will take stikinumab 90 milligram sub-Q every 12 weeks or stikinumab 90 milligram sub-Q every 8 weeks. And those patients with delayed response, if they have a response, they will continue on stikinumab 90 milligram sub-Q. What are the endpoints? What are the target of treatment? The primary endpoint at 8 weeks is clinical remission. And here they use either the global definition with a Mayo score less than or equal to 2 with no individual subscore, or the US definition which use the absolute stool number less than or equal to 3, rectal bleeding subscore 0 negative, which is a very stringent endpoint, and Mayo endoscopy score, which is 0 or 1. The secondary endpoint at week 8 is clinical response, endoscopic healing, histologic healing. They go far beyond endoscopic healing, and they searching for histologic healing and total mucosal healing when they combine endoscopic and histologic healing. And again, what is that reflected on the overall quality of life? To tell you some point about the characteristics of patients, you can see on this red box that about 50% of patients, 49.5, they has biologic failure, and 50% use one biologic agent or more than one biologic agent. So you are dealing with a tough group. Patients, half of the patients, they lost response to one biologic. Also, they have median UC disease duration. They have a disease of almost about 6 years duration, and about half of patients have extensive disease. So the study selects patients with a bad patient profile or difficult patient profile. Also, short note about the biologic medication therapy, they use about one anti-TNF, about 35%, not to VIDO. Any anti-TNF and VIDO, يعني here we use anti-TNF and one anti-integrin, about 15%, or VIDO in 15%. Again, you are dealing with a patient, a category of patients which failed systemic therapy or conventional therapies, then failed one biologic, and at sometimes one anti-integrin, and sometimes both anti-TNF and one biologic. So they are a difficult to treat group. What about the impact on clinical remission? Here we will divide our patient if they are biologic failure or non-biologic failure, or biologic naive or biologic experienced. We will find that after 8 weeks, about 20% of patients who didn't use biologic before have a clinical remission, and the results is almost better than the previously used biologic or with biologic experienced one. If we use the US definition with different criteria, we find also patients without use or biologic naive, about 25% of patients biologic naive, they are almost have clinical remission. Those with biologic experience before were 13%. So it's evident if you use ustekinumab in biologic naive patients, you will have, at least at the first 8 weeks, you will have a good response. Now, the situation is not only to have clinical remission. What's reflected on the histological improvement or during histological assessment is important, because now we are ambitious to have a patient with histological improvement. And this histological improvement, as we will see, will be reflected later on the recurrence of symptoms, on the periods of relapse. Healing by biologic failure at 8 weeks, you will find about 1/3 of patients just after 8 weeks, biologic naive patients, they have a good endoscopic healing in comparison to 20% where for patients biologic experienced or failed one biologic before. The question why we need histologic improvement, because it's linked to good clinical outcome, such as reduced risk of operation, need for surgery, and hospitalization. We combine in histoendoscopic healing again at week 8, which is a very early period. We find that about 20% of patients have a good and have a histoendoscopic healing, which is a good result. What about clinical response? Not clinical remission. Here, the clinical response of the patient reflected by decrease in the number of bleeding per stool, decreased number of stool per day. We find that at week 8, about 66.7% of non-biologic failure before have a good clinical response in comparison to about 60% with biologic experience before. Again, when you find this clinical response at week 8, that's good and that's satisfied at least during this period. So, clinical response by biologic failure states at week 8 and 16. At week 8, we find patients, about 67% of non-biologic failure patients have good response, and 62% for the overall, including those who used before this drug. Also, more than 80 for patients with non-biologic use before, and the 80 for the overall population of the study. That's at week 16. The condition we cannot judge only by clinical remission and the clinical response. We for sure we have clinical and endoscopic and histologic, but about fecal calprotectin, which is a marker. We use it for monitoring our patients. We find a good response and a good decrease at week 6 and week 8 using this fecal calprotectin. So the other side of the situation, whenever you are talking about efficacy, it must be linked to safety. What about safety of this patient? Here we find that ustekinumab and placebo as regard adverse events, as regard infections and serious infections, all the items are comparable to placebo. No evidence of more or increased rates of malignancy or increased rates of opportunistic infections more than placebo. So, in general, a single IV administration of 130 milligram or weight-based 6 milligram per kg ustekinumab was well tolerated through week 8. No dose-related safety events were observed. Again, adverse events similar across treatment groups. Serious events were not commonly reported. There is one death attributed to esophageal versus hemorrhage reported in a patient who took 6 milligram per kg. Rates of infection are not more than placebo, and the adverse events occurring within 1 hour of an infusion, there were no cases of anaphylaxis. What about maintenance? Whenever you are talking or examining or try to know the effect of a drug, it's not for the induction of remission, but the story will be what about the maintenance? Is this remission which was induced is maintained? That is the story, because we have our old drug steroids. Steroids are very good and very effective in induction of remission, but the story how this effective induction of remission will be maintained. Here, as we see, patients who gave a good response at the primary endpoint, which is week 8, they maintain through week 16 to week 44. The primary endpoint, which is clinical remission, as you see, according both global definition and US definition, they are 42.6 according to US definition after 44 weeks. And in global definition 43.8. So nearly half of patients at 44 week after successful induction of remission, or who meet the criteria of primary endpoint after 8 weeks, they show a good response after 44 weeks. What about clinical remission by previous biological failure status? We find that in those patients who are non-biologic failure, about 48%, biofailure, bio-naive, about 50% of patients, and even those who were filled for more than one TTNF or one anti-TNF plus FIDO, they all still have a durable remission and a durable situation after 44 weeks of the study. So even the naive patients or the tough or difficult to treat patients who show a good response and still till the 44 weeks after therapy, they have about half of patients have the same response. What about the maintenance according to clinical response? Here we have 71% have good clinical response, and here we are comparing those who took it every 12 weeks versus who took the drug every 8 weeks, and nearly the same response as regard 8 versus 12 weeks. What about endoscopic healing, which is a measurable one? Here about 51% of patients who take every 8 weeks in comparison to about 44% with 12 weeks Stickino-MAP. The same histologic the same response with histologic response or histologic healing. So we are talking not about an efficacious drug only, but it's a durable remission, and that is the most difficult part in the treatment of ulcerative colitis. Again, with mucosal healing, again with steroid-free remission, which is a very important point, how your patient will not need to be every time needs to be in steroid to induce remission. Again, the sustainability of the low fecal calc protector, which is a measurable indicator for inflammation. And also all these are reflected in IBD quality of life score. We are not talking only about lab or about endoscope. How this is reflected for the patient quality of life is very important. So for time, I will not repeat again, but it's a durable situation. What about key maintenance according for those cases with delayed response? As we see before, some patients give a good response at 8 weeks, and some patients didn't give response at week 8, and we continue at week 16. Those delayed responders, and this is very important, and that sometimes we are facing these patients who are delayed in response. Here is a study tell us not to withdraw and to give them a trial till week 16, because good response, some patients show a response, as we see with those with Stickino-MAP 6 milligram weight-based, they show about 58%, and those with IV 130, which is a fixed dose, they give 60%. Show those with delayed response show clinical remission and the endoscopic healing. So this is a point which is very important when we are dealing with this drug. Again, sometimes we are facing patients, all of us know that the combo therapy in the anti-TNF is better than the monotherapy. But in certain situations, whenever you are treating a patient who is old, a patient with comorbidity, a patient above 65 years or has before some side effects of the immunomodulators, either azathioprine or methotrexate, you cannot use the combo therapy. What about Stelara as a monotherapy? It's very important in Stickino-MAP for two items. The first one, the efficacy of monotherapy is nearly equal to that of the combo therapy. The second one, as I show in the first slides, it has a very low immunogenicity, not more than 4. Sometimes we use an immunomodulator to decrease the immunogenicity of the anti-TNF. Here we cannot, we don't need that. So whenever you are using your drug in a patient, old age patient or very young patient or a patient with comorbidity or with a serious comorbidity, I mean, or concomitant liver disease, in a patient you don't need to, you don't want to use an immune modulator. Here, the choice of ustekinumab as a monotherapy is very important. So, and this will take us to the tailoring of the drug according to your patient. He's young or old, he needs mono or double therapy, he has comorbidity or not, he is has malignancy before. That's very important because we are frequently asked this question: when to use ustekinumab or vedolizumab as a first line, not a second line? Again, immunomodulators didn't affect serum scleral concentrations here in Crohn's disease because used during the last 3 years. And our drug is not immunogenic here. We don't need an immune modulator. What about the safety after 44 weeks? So we have a good drug at induction of remission with a high safety profile. What about 44? What about the durable remission? What about the safety? Is it present throughout the study? Yes, again, it is not different than the placebo, and the serious adverse events were very minimal, and the malignancies, excluding the non-melanoma skin cancer, again, it doesn't differ from placebo. So we have a drug with a very high safety profile, and even the recorded death or some serious infection, they are very limited number, and mostly are not related to the drug, or if opportunistic infections, it is very, very minimal and can be treated. So the safety profile of our drug is very evident. As this is the last slides, so we don't have head-to-head trials which are examining the different biologics, and they can tell you which to start and when to use this drug and when to don't use this drug. But if we have according to this pooled treatment arms, we have ustekinumab with a high efficacy, about 70%, in comparison to the other tufa or adalimumab or golimumab or vido or infliximab. It's a very good at induction of remission. Also with clinical remission at 1 year, also again with pooled treatment arms, because as I said, we don't have mega studies with head-to-head trials. So فبنلجأ للpooled studies or للميتا analysis علشان نقدر نشوف which drug is more effective than. طبعا all these studies لا تغني أبدا عن الهيد تو هيد studies، لان الهيد تو هيد studies they are the evidence based اللي احنا بنستخدمه. The last one, we are very when we revise how to use it. If we use the fixed dose 1/300, if your patient is less than 55, you need 2 more than 55 kilo, 3 more than 85, 4, and again they are convenient with no side effects. Even if you use it, the recommended schedule is every 12 weeks, except in certain situations when you need to be 8 weeks. If it is in comparison to the Vido, anti-integrin, and the adalimumab, they are less than them. So in UC and the Crohn's disease delivers 10 years heritage, which is الهeritage الإرث أو التركة. فهو مش 10 years in IBD, 10 years in other indications, in rheuma, in arthritis, in derma. لكن ده بيدي indication على السيفتي. Efficacy from a single IV dose is very important. Lasting efficacy and the consistent safety profile with convenient dosing. And thank you.
Thank you very much, Professor Afifi, for this very elegant talk about secukinumab. You give a complete coverage of the subject. Just a question about histological remission and clinical remission. And in one of the slides, histological remission exceeding 50%. So is that goes with the clinical or?
Yes, because sometimes the clinical remission is not full remission, but whenever you are talking about clinical remission, there is difference between clinical remission and the clinical response. Clinical response means some improvement, but in clinical remission here, Mayo subscore as regard the bleeding, it's near 0, and your Mayo score is less than 3, more than 3, the original Mayo score, or more than 30% reduction. So the clinical remission is better than. I didn't say the clinical is not a good indicator like histological, but clinical remission means nearly complete response of the patient. Sometimes we have a histologic remission, which is still not reflected on the clinical response of the patient.
Thank you.
Dr. Mahmoud Al-Majid.
Thank you, Professor Afifi, for this elegant presentation. I'm asking about the Unify study. You have a placebo group in this study. Is it true placebo, or it is another medications, because it is not ethical to leave a patient with active ulcerative colitis for 16 weeks without any medications?
No, it's not placebo. It's not without drugs. This patient is on the traditional drug. Some patients with 5-AZA and some patients were on a low dose steroid. It's not true placebo means nothing, no.
So I wonder why we are titled it placebo. We can say conventional compared to secukinumab, because placebo has a false impression about the management of this group. What's your opinion?
My opinion, as you said, to change from true placebo to versus conventional therapy, I don't have the answer. My professors, the chairpersons, Professor Baha and the Professor Amr, can say something about that. But that is the study design, and to my opinion, if we will combine, you will, if you wanted to make a different, يعني عشان نقدر نحدد فعلا الفرق بين الترو conventional therapy والbiologic therapy, ده هيبقى from the start من الاندكشن. انما I think you choose a patient at a time. He is out of steroid or he is of low dose steroid. So this group, which is a placebo group, collectively is a heterogeneous group. But if we wanted to try between conventional and biologics in a group in one study, you will choose the correct dose and the correct regimen. I think that.
It is a placebo for biologics, but not for...
Yes, this patient is not on a true placebo.
Yes, thank you.
Dr. Afifi, last question. I want to make the message more clear. What are the indications of Stelara in patients with ulcerative colitis? When to give the medication?
In patients with moderate to severe ulcerative colitis, it may be used in certain situations as a first line. It may be used after failure of the conventional therapy. It may be used after failure of anti-TNF. So the three situations in patients with ulcerative colitis, either bio-naive or bio-failure, you can use your drug. What are يعني ايه النقط المضيئه اللي تخليني to go to secukinumab? As I said, if you have a patient, you cannot use an immunomodulator. In a patient with previous history of malignancy, in a patient with comorbidity, However, you are a compelling indication. A patient with extraintestinal manifestation, he has ulcerative colitis and he has psoriasis. So, for that, Professor Amr, so you are tailoring your treatment according to the profile of your patient. Use in moderately to severe ulcerative colitis in a different situation, either bio-naive or bio-failure or after failure of the classic therapy.
Okay, thank you very much, Professor Afifi. Thanks for my co-chairman, Dr. Abbas, and thank you for all. We are closing this symposium, and let me